Good afternoon, everyone, and welcome to today's Spotlight webinar. We're delighted to be joined by people from coast to coast to coast, and feel free to type into the chat box your introduction so that people know where you're joining from and get a sense of who's on the webinar. My name is Jennifer Zelmer. I'm with the Canadian Foundation for Healthcare Improvement, and we're delighted to host today's webinar on what we've learned so far from the High River Meat Plant outbreak response, joined by so many partners who've been involved in that response. And I'd like to begin today's webinar by recognizing that because we are coast to coast to coast, we are gathered today collectively on territory that has been inhabited by Indigenous people since the beginning. I'm personally joining today from Ottawa, the traditional unceded territory of the Algonquin and Anishinaabe peoples, and I'm so fortunate to be able to live and work in this territory. Today our tradition is to look at what can we learn, what can we share all across the country, and to bring different voices to the fore. I'm delighted to be joined today by different panelists bringing different perspectives, and before I introduce them, I just want to make sure that I've reminded folks that si vous voulez écouter en français, veuillez désactiver les haut-parleurs de votre ordinateur et composer le numéro sur l'écran. Thanks so much for joining us. So with that, I'll introduce our four panelists today. Cesar Cala from the Philippine Emergency Response Task Force, Brent Friesen, Medical Officer of Health and Chair of the Task Force for the High River Meat Plant, Deirdre Lake, Executive Director of the Alberta International Medical Graduates Association, and Annalie Coakley, Medical Director of Mosaic Refugee Health Clinic. And each of them will share their perspectives on the response in terms of what we've learned so far. And as we do that, I think it's important for all of us to think about this in the context not only of meat plants, although of course there have been outbreaks at meat plants in many parts of both Canada and the world, but also leading up to this webinar, we've had a number of people contact us and say, you know what, this is so relevant for this other settings and other contexts that may also have congregate workplaces or other characteristics that are similar. And so we owe it to all of those affected to share these lessons and learn from each other. So Cesar, with that, I'm handing it over to you to start us off. Thank you so much.
Well, thank you so much for this opportunity to discuss our experiences at High River in the Cargill plant. Let me start by saying we are calling this a crisis within the pandemic because not only because it's the largest outbreak in Canada and I guess it's in North America, but also the specific context of the workers, but also the larger community around the meat plant. So let's start with the numbers. Cargill employs about 2,300 workers, but many of them live in quite large households or share their households. And so we were thinking that the actual footprint when we talk about Cargill is around 16,000 to 20,000 people. That's a big number. And spread across 3 municipalities. Although Cargill itself sits in High River, many of the workers, a large portion of the workers, actually live in Calgary, which is about 30 to 40 minutes drive away, and also in other municipalities, especially Okotoks. It is a very racialized workforce, which means people come from different racial backgrounds and languages. I think that we have about 70 to 80 languages, first languages spoken at the plant. It's also in a work environment that requires people to be very close to each other, as you can see in the picture. This is the fabrication floor, and there's a kill floor as well. And there's very specific social economic conditions of workers and their families that make them more susceptible to infection. Next slide, please. Next slide. Okay. So the workers, many of the workers are new to Canada, whether they are temporary foreign workers or what we call PFWs, or refugees, or people who have recently acquired their permanent residence in Canada. And this is important to understand because many of them are really tied to their employer. The PFWs have what we call a single employer visa, which means that their stay in Canada is dependent on their stay in their employer, in this case, Cargill. Many refugees also have a hard time looking for employment elsewhere. And those who have stayed on, who have become permanent residents, have really connected economically to their life at the plant. Many are also here alone, and especially PFWs, their families, when we talk about families, they're back home. And so there's a lot of economic burden on a lot of these people, of the workers. And Cargill has become more of a gateway for a better life in Canada. So there's a need among the workers to share resources. So in other times, these have been very important for them, like sharing transportation through carpooling and households as well. So on the average, we have seen households of the size between 5 to 8, and sometimes it's more than 10. It's also quite risky employment, right? The nature of the plant itself entails a lot of risk. What also exacerbated the situation is that they are working in a wage and pay system that are fraught with challenges. And so they're paid by shift. And so oftentimes people are asking, will we get paid because we didn't work in a pay shift? So what also was not very helpful was during the pandemic, there was a bonus system for people if they are able to work through the time, I think a couple of weeks, that they are amenable, they will be able to get about a $500 bonus. Next slide, please. And so when the Cargill factory closed down, the workers themselves felt that they are being blamed for the outbreak. And what they heard from many public officials, inadvertently sometimes, but what they heard that it's their fault. That's why the infection has spread. And so, but we also know that many of them have actually raised the alarm really, really early on. So next slide, please. And so we also take this opportunity to give a human face to the workers. Hip Boy was there, worked for more than 20 years. She was the first worker who have died. Recently, another worker who came from Mexico, Benito Quesada, who worked there for about 10 plus years, have also perished. And from what we heard, 6 people have died already. And the other fatalities have come from the households. So at this point, I want to turn it over to Dr. Brent Friesen.
Brent, I think you're on mute.
Thank you. So how did we get to an outbreak with over 948 employees and over 600 household members? Well, first, let me assure you that this can and is likely to happen in your jurisdiction if it has not already occurred because of the structural and systemic factors that enable and support the spread of COVID-19. And Cesar touched on some of those. We were like any other jurisdiction in Canada at the start, and that with initial COVID-19 cases and travelers and close contacts of travelers. Our initial public health guidance was focused on daycares, schools, bars, recreational areas, large gatherings. We were emphasizing the importance of physical distancing, hand washing, staying home if ill, and that continues to be the key public health guidance that we're providing. What we did not recognize is that within our population that we served, that there were people who were not being reached by our messaging because of language or cultural issues, or if they were understanding messaging, they were unable, hence the title of this slide in terms of essential workers willing but unable. And so why weren't they able to follow the advice and that? Well, they did not have the resources to comply, or they were required to work in workplace settings as essential workers for part of the food supply system. To be going to work, Cesar has also touched on some of the other very individual reasons as part of their conditions of being in Canada that they had to go to work. But they were required to work in a workplace where physical distancing was not possible and where the alternatives to physical distancing were not available or accessible to them. We were made aware of the first lab-confirmed case in the Cargill facility on April 3rd, and then our environmental public health people had undertook an inspection with the Canadian Food Inspection Agency on April 7th. At that time, a number of recommendations were made to install barriers between the people on the fabrication floor. You saw those people in the slide earlier where they were working side by side. One of the changes was to put up physical barriers to separate them. Areas where there couldn't be physical barriers put in place were to recommend the use of visors and masks. The sort of measures that we were requiring in our healthcare facilities in order to protect healthcare workers where they couldn't be physically distanced from the patients and that they were caring for. There were recommendations around increased hand washing, use of hand sanitizers. Some of the practices that were contributing to the spread in the facility is that as a food production facility, workers were required to wash their hands and use a chlorine dip, a hand dip before going into the cutting area. They had a 2-tap sink, and there would be 8 to 10 people crowded around that sink washing their hand at the end of a break or end of the lunchroom before going back onto the plant floor. And people could be from anywhere within the plant in terms of the fabrication or kill floor. In hindsight, the virus was introduced into the plant in mid-April. I mentioned we were there for the inspection on the 7th. The peak of infection among the workers ran from April 7th to 10th, and in the household members from April 13th to 15th. As a result, to coordinate the response to affected employees, household members in the communities, Alberta Health Services established a task force. As an integrated health care system, we have long-standing close relationships with primary care providers and with community agencies, so we were able to bring the task force together quickly. Our initial priority was on case identification and contact tracing and support to individuals and household members to safely self-isolate as part of our containment strategy. The environmental health staff mentioned that earlier in terms of that they were focused on measures to help reduce transmission within the plant. They also were involved in responses to foci of transmission in the community. For example, some of the household members worked in fast food establishments, grocery stores, and so we were seeing cases occur in these other settings. And they were collaborating in their work with the Canadian Food Inspection Agency and with Occupational Health and Safety in other meat processing plants. So we were trying to apply in real time what we were learning in Cargill and another plant, Harmony, to other meat processing plants. With the help of our Health Link, or 811 as it's outlined in the slide there, we were able to rapidly arrange for testing of cases and household contacts within a 24-hour period. So if someone called in and that we could get them set up and have that test arranged within 24 hours, and often the results would be back within that period of time. There was a drive-through testing site that was arranged in High River to make it more accessible to people. Again, a number of the workers were challenged in terms of access to vehicles and that to to be able to get to testing and committed in terms of following the recommendations around self-isolation. And so we've told them to stay at home because they're potentially infected, but they're having difficulty in terms of to get access for testing. The epidemiologists played another key role in terms of helping to understand the what was happening as far as the transmission and linked to other sites. I mentioned the food facilities. There were also linkages into a number of our continuing care outbreaks in High River, Okotoks, and Calgary area. They also played a key role in managing the large volume of data. Communications were important. Next slide, please. In making contact with the employees and with municipal elected officials and other key influencers in the community. Our town halls with the employees were not as successful as we'd hoped, even though we were using the Association of International Medical Graduates to help with the translation. You know, prior to COVID-19, we had 7 CD nurse contract tracers within Alberta Health Services doing our CD follow-up. And that in order to expand our contact tracing capacity, volunteer medical students, when the medical schools were suspended as a result of public health directives, the medical students became available, were interested in volunteering, and so they were recruited and trained. Jacques, Dr. Hu, is on the call with us here. He and a couple of other colleagues and senior residents helped with that. It takes about 90 minutes to 2 hours, including documentation, to complete a contact. And so with those 2,300 employees and their households, we were able to do the equivalent of 4,600 hours of work over the course of 2 days with more than 100 medical students, and again arranging for that access to testing, facilitating the self-isolation, as well as identifying households that were experiencing food insecurity, which led in terms of to our next speaker, in terms of Deirdre will speak to what they encountered when they were supporting the household. So Deirdre, over to you.
Thank you. So the next slide, please. Thank you. So our community outreach team comprised of CCIS, FCIS, Action Dignity, PERT, and AIMGA. So together we were assigned with the task to call over 1,800 of the employees in a 48 to 72 hour time frame, and those calls took place from a Friday to a Monday. So over 50 callers were provided with an orientation, and the names were allocated based on potential languages spoken, and the calls began. Next slide, please. So in terms of the top 3 concerns when we contacted the members of the households, first and foremost, employees were fearful, particularly having learned that one of their colleagues had recently passed away at the time of the plant closing. Concerns regarding their health and the health of their family members within the households was of great concern, and as mentioned, it wasn't uncommon to have large households. One household, for example, that we had contacted had 16 people residing in the house, 11 of which, of whom who had been tested positive for COVID-19 and were isolating in the basement, and then the other 5 were isolating on the main floor. So most of the families had opted to isolate at home as opposed to going to an isolation hotel. So there was a lot of education that was needed in terms of in first language, in terms of what isolation meant, the difference between self-isolation and isolation, those who were positive versus negative within the household, and so on. And also when to call 811 or to seek medical attention. So one woman, for example, who had expressed feeling too weak to stand was immediately put in contact with the medical officer of health on the task force, and then other people that were of concern who had comorbidities, for example, were connected to the primary care doctor where further follow-up took place. So the second most pressing concern were financial concerns. So there was a lack of communication from the employer, and this was an issue. Payments were delayed for many. For those who were being tested, who were tested positive, they were being recommended to fill out WCB forms, and of course help was needed in this regard. So both their personal and their economic safety were at risk. And then thirdly, as mentioned, food security was an issue because people needed to isolate safely. And this support, actually, this ended up being a large challenge for our community task force because time was of the essence. And on the weekend, some of the food banks were closed. As mentioned, the households were dispersed through Calgary, High River, and Okotoks. And so there were questions around jurisdictional responsibilities, and coordinating, these supports within the crisis was a challenge. So for those we were able to provide culturally appropriate food boxes, this was highly appreciated by the families. And also having people call households in first language was effective, as some of the individuals were reluctant to accept food despite needing it. One individual, for example, was fearful that accepting food might have a negative impact on his ability to sponsor his spouse in coming to Canada, because of course financial independence is a key factor in family-sponsored approvals. So yes, thank you, the last slide. So the community task force provided supports in first language and brought cultural awareness to the team. And AIMGA, as mentioned earlier, provided supports on the AHS Town Hall in terms of interpretation. And we also are proud to have said that we developed over 75 educational videos around COVID, which are available on our website, and we'll put that in the chat. And these videos were dispersed, within the meat plants and to employees, and have been circulated widely. And so those provided first language supports. And Action, Dignity, and PERT had arranged information on financial supports and a memorial service for the woman who had passed away. So all in all, I'd like to say it was an intense time period for all those involved, but responding to the needs of newcomers is what we do, and coordinating, this and doing so collectively was what was needed. And so we continue to provide supports and services in ways that we can and coordinate these supports within our sector. So I'd like to pass it over to Annalie now. Thank you.
Thank you. So I'm Annalie Coakley, and I would like to illustrate the role of primary care and community agencies through one of my patients' journeys. And so my patient is Asha. I've been her family physician for the past 2 years when she came to Canada as a refugee from Somalia. In Somalia, she lost her husband. He was killed, and she was left a widow and a single mother to 4 children. So she left her children in the care of her extended family in Kenya, and she eventually made her way to Calgary. Next slide. So in Calgary, shortly after her arrival, she found her job at Cargill on the fabrication floor of the plant. She loved her job, and she loved her job because it gave her an income to be able to not only support herself, but to support her family in Kenya. And then, of course, she was thrilled with the bonus that Cargill provided during the pandemic to those workers who would work 8 consecutive shifts, because as she said, that money would go a long way to supporting her children back in Africa. Next slide. So when the outbreak first started at Cargill and became well known in the community, her landlord evicted her from her home, where she lived with both him and his elderly mother. And so, of course, she was panicked because she wasn't sure how she would find housing during the pandemic, but she's also very resourceful. So she ended up finding another room to rent in a home with 5 other people. But the few days before she was due to move, her coworker told her she would need to get a COVID swab before she would be allowed to return to work. So she went and she had that swab done, and then the day before she was due to move, Public Health contacted her with the results of that swab, and her swab was positive. Next slide. So Asha was devastated. She wasn't sure, one, she was frightened about her diagnosis, and she wasn't sure what she would do. Public Health told her she would need to self-isolate for 10 days, and she didn't know how she could do that when she was due to move out of her home the following day. And she also didn't want to move into another home with 5 strangers when she was COVID positive. So she really began to panic. And this is where I became involved, because Public Health had contacted me, and then I subsequently contacted Asha on the phone. So after completing her health assessment and determining that she was clinically stable, we dealt with her social issues. So first, the first issue was around isolation. And so in Alberta, the government of Alberta provided people in need of self-isolation the option of a hotel, food included, for the duration of their isolation. And so Asha graciously and gratefully accepted that offer. Next, there were the issues regarding her housing situation. So she was due to move the next day, but she needed to go to the hotel for isolation. So what could she do? And so to that end, I connected with CCIS, one of our local immigrant serving agencies, and the counselor at CCIS ended up paying the landlord an additional 10 days of rent so that Asha could leave her belongings in place. And he made all the arrangements for her move following her isolation period. So in addition to all of that, CCIS also arranged for her to have culturally appropriate food, because she was isolated during the holy month of Ramadan, and it was very important for her to break the fast with culturally appropriate food. So CCIS had also made those arrangements. Next slide. And so, of course, with Asha disappearing for a period of 10 days, the landlord became suspicious that she was diagnosed with COVID, and he started to leave her very threatening messages on her voicemail, so saying that she would be held accountable if either he or his mother developed COVID. And so, of course, this was very distressing for Asha, and fortunately, the counselor at CCIS was able to connect with the landlord and mitigate his threatening behavior. Next slide. And so over the course of her stay in the hotel, Asha had daily health assessments with me. So we would do daily health assessments. I would provide her psychological support because she had a lot of anxiety during these very difficult times. I was able to deliver medication to the hotel when that was needed. CCIS also connected with her daily just for that emotional support. And eventually Asha's symptoms fully resolved, and she was able to return home and move into her new home with the help of CCIS. None of Asha's household contacts were infected. And so I think Asha's story is a perfect illustration about how primary care and community agencies can work together to not only address the individual patient's needs, but also to curb the pandemic. And now over to Brent.
Thank you, Annalie. And just start out with moving forward. Is most important thing is to know who your friends are and to make new friends during COVID-19. I think look to your organization and community assets. In Alberta, Calgary zone, we were fortunate in terms of Amiga, and that we had the medical students, we had the foundations that came together to help support the response. I think we were distracted as an organization initially with a focus on preparing our health care services to manage or respond to a potential surge that distracted us from the real issues and real risks within our community. And it's going to be important going forward, remembering and focusing on the fundamental determinants of health as a key component of our COVID-19 pandemic response. Next, Cesar, for you to wrap up.
This is also an equity story because we can see the differential treatment between classes of essential workers. So many of the workers in Cargill have always been told that they are essential to Canada's food supply, but the initial treatment they get was not consistent with that idea. So even when they hunkered down in their neighborhoods, with the story that Annalie shared, for instance, many of these discriminatory attitudes really hounded them. But moving forward also, it's important that we increase the voice of the workers in really understanding the situation. Many of the workers actually raised the alarm quite early in March when they approached the company to say that there's spread happening in the workplace. But those concerns were dismissed. So it's important that we see the workers not just as an object of our intervention, but partners in the way forward. Making workplace safer from input from employees, that's very important moving forward, because they live the realities day to day, not just in the workplace, but also the larger context of their households and their connections to the community. And so that's an important lesson that we need to learn from this, is that the workers themselves can be partners moving forward. And finally, I think Brent mentioned this already, that this also lays bare some of those vulnerabilities that have already been in place before the COVID-19 pandemic that have made people more vulnerable, more susceptible to this kind of infection. And some of the issues may require more long-term efforts, like the whole policy around temporary foreign workers and single employer visas. That would take a larger kind of initiative beyond the scope of our collaborative. But it's important to understand the different aspects of their lives and of the workers' lives in their communities for us to be able to support the strengthening, the resiliency of the workforce in this particular case. So thank you very much, and I think we're going to open up for questions on the floor.
Thanks so much all, and really appreciate all of you sharing how the situation evolved and some of the responses along the way as well. For those of you online, feel free to type questions into the chat, as some people have started to do. And maybe just to start things off, there's been a question around how do we support the voice of workers, the voice of communities in early stages of an outbreak? How do we address the kinds of issues you just spoke about, Cesar? Did you want to start?
Sure. There should be mechanisms in place that would look into the concerns of the workers in a really more formalized way. More than 200 workers actually signed the petition, but they were dismissed early on, right? But their concerns were proven right. So there should be some mechanisms and structures in both looking at safety in the work plan and more proactively what needs to be happening to move forward and create a safer workplace.
Anyone else want to jump in on that one? Brent? Oh, Brent, you're on mute again. Oh, there we go. You're good. You're good.
Yeah. There are some formal structures, such as the joint workplace health and safety committees that many of our provincial workplace health and safety laws require. I think what was unfortunate, not more than unfortunate, tragic in terms of Cargill was based on the information we've heard from the union, is that committee was not working as it was intended to be, and allowing issues such as the concerns of workers around the spread being brought forward. So again, things that can be done working with unions, other groups as well as employers to help improve and address these issues.
Thanks, Brent. There's also been some questions. I'll just deal with a process question for a minute. There's been some questions about whether the recording of the webinar will be made available, and yes, it will be. So for those of you who are desperately scribbling notes or trying to record down information, you will have access to that. But picking up on a broader question, I think many people were commenting on the chat on the importance of the broader community response, and the fact that there was a real mobilization of community agencies, of primary care, and of others really fulfilling that it takes all of us to move forward. Annalee, I'm wondering if you want to jump in first on this question about what worked well in terms of mobilization of community response, and any thoughts that you might have looking forward that would be good advice for others.
I thought the community response worked really well. Like I was very impressed with my community partners, so PERT, EMGA, CCIS, FCIS, like they mobilized very, very quickly and helped address like all of those contextual factors that we as health have a difficult time addressing, and which are key to curbing the pandemic and ensuring the health of the workers. And so I felt like, to me, that's the aspect of the response that I'm most proud of.
Fantastic. Deirdre, anything to add? Because you guys jumped in and did a million different things.
Yeah, we jumped in very quickly, and I think that speaks to the sector. We quickly sort of organized ourselves, and got the languages that were needed sort of on deck, and so did so in a very short period of time. But I think that, we weren't really prepared in some sense for, the food supports that might be needed for people to isolate safely. And definitely, having the employees, educating them in first language was essential. There was so much support that was needed, around isolation and what that meant, and how to do so safely. And, a large amount of fear around that. So certainly using the international medical graduates was instrumental in that regard. And I think that, just a takeaway for our nation, that we are, a diverse nation, and I hope that in the future more employers, start to collect the languages of their employees and the languages that they do speak, so that if something does happen, that, we're even able to respond quicker in the languages that they require, and with culturally appropriate responses.
Thanks, Deirdre, and a really practical suggestion there as well. Cesar, I wonder if I can hand the next question over to you, because you spoke about this in your remarks, and the issues that occurred around stigma in the various environments. Do you have thoughts about how we could mitigate that risk, how we could address issues related to stigma?
Yeah, so this is connected to what I was going to add to the previous question as well, because part of the contribution of community partners, in this case, INGA, Action Dignity, and ourselves specifically, is to look at the cultural and social context of the workers. And to provide advice on how social services supports can be provided in a way that is culturally appropriate, like the food supplies and the messaging around safety in the workplace, but also safety in the household. So that's an important piece of the puzzle. The other piece, and it's connected to the stigma, is really to also be kind of an informal conduit of what we're hearing from the ground. So, for instance, the sense of blame we heard that quite loudly from the various workers that we talked to. And inadvertently, the initial proclamations or the initial communication, even from unintended, but from public officials, was around a feeling of being blamed for the spread, right? And then when the actual plant closed, then this sense of stigma followed the workers in their households and in their neighborhoods. So we heard of instances when workers were not being allowed, even if they didn't have symptoms, were not being allowed to go into groceries, for instance, or are being reported on by their neighbors. So part of our role was really communication and advocacy, so that we were advocating for a change of narrative, that workers themselves are part of the solution and that they're not to be blamed entirely for the outbreak, and the workers themselves are saying that we need to look at accountability of the workplace where the spread is happening, but also enabling workers to feel confident and empowered to share their concerns to a larger public. So that has been our role as well. So I think it's important to see community as providing the platform and providing advice and even resources to provide the supports like food and other social services, but also to be a proxy voice for the workers and supporting them to actually come out front with their own concerns.
Thanks, Cesar. And special shout out to those of you who've been adding comments into the chat and answers into the chat to some of the questions as well. Annalie, I noticed you'd added one in the chat. Did you want to jump in on this too?
Well, I mean, I think I agree with everything that Cesar is saying, and I think it's much more than just stigma, like it's overt discrimination. Like I've had several patients evicted because they were Cargill workers, not because they were positive, but because they were Cargill workers. And so what message does that send to these workers when they're in fact the victims of their workplace?
So many broader issues, hey? Brent, I think this next cluster of questions is probably for you. There was a couple of sort of public health response specific questions, whether you had a sense of the importance of the role of asymptomatic transmission, and if you could speak to how public health linked in with this broader community in primary care, in the community, as part of the response.
Yeah, again, we're still, work is still occurring on analyzing the epidemiology there. My sense is that our experience is that the asymptomatics didn't play any greater role in this this particular outbreak. When we did the mass screening or screening for the asymptomatics, one of the things that we did find is that a number of those that were initially asymptomatic at the time of the testing went on to develop symptoms, so they were caught in terms of the pre-symptomatic phase. But I know Amanda's on in terms of the chat, and she may want to add something to that. And then, Jennifer, I'm sorry, what was the next question you were wanting?
All good. Really not fair of me of throwing two at you at once. So it was, how did public health link with other partners to support the outbreak response? I mean, you guys had a lot on your plate too. How did those connections work?
Well, I think it gets into with Alberta Health Services being an integrated health system. So we already had existing relationships with the various components of the health system. As a zone, the way we're structured in Alberta, the Calgary zone includes the city of Calgary as well as surrounding outside communities, which includes High River and Okotoks. So we had linkages into the hospital and clinics in those areas, and so we were using that existing structure of our, as an organization, of our emergency response structure to help direct this response. What we found is that we needed the task force structure to really bring together an action-oriented group, and ended up, I think, we estimated there were about 200 people, or greater than 200 people if we were factoring in the medical students that were specifically focusing on the responding to the needs of the Cargill employees and the households.
Thanks so much, Brent. There's a series of questions, and I think several of you may want in on this one. So maybe, Deirdre, I'll start with you just to give you warning, but I'll throw it to you first. Around, so looking ahead, the pandemic is not over. How do we think about building on what you've learned here in preparation for potential future outbreaks? What's that look forward, so next step?
Definitely for us, education is prevention, from a health perspective. But I think just picking up on the needs of newcomers, and in particular temporary foreign workers, and sometimes the fears that they have about speaking out and about their job security and so on. And so, that's something where the sector really needs to come together to provide those supports, and make sure that we're doing a great job of doing that and following up with individuals. So I know that one of the things that we're doing is following up with those individuals that have been called, and reaching out to them in different ways, and really figuring out what is the best way to get information and out to newcomers and to hear their concerns. And certainly the immigrant serving organizations are a great option for that, and know their clients and know their workers. But I think for North Americans, for example, in terms of how we like to communicate, or we may be very tech savvy or go onto the internet to look up information. And so even just learning the trusted sources within community and how to best reach newcomers and to hear their concerns so that we can respond accordingly.
Thanks. Annalee, anything to add from the primary care perspective looking ahead?
Well, what I was thinking about is I think we as primary care physicians should reach out to our patients and actually help them come up with an action plan. If they were to become sick, what do they need to have in place, instead of having this panic at the last minute when they're feeling very unwell and their families feel like they're under threat? Like, what do they need to plan for in terms of financial support, food supports, social supports, and really have an action plan ready to go? And I think family doctors are in a good position to discuss that with their patients. So that would be my suggestion from a primary care point of view.
Great. Thanks, Annalee. Cesar, what about from your point of view? Looking forward, what do we need to do?
Nodding my head around action plans when Annalee was speaking, because PERT and Action Dignity are actually working on a community and collective action plan as well. Many of the workers are also involved or connected to their own ethnocultural communities, and actually during the pandemic we have seen a big surge of support from those communities. So now we're doing a lot of consultations on what they think should happen henceforth in terms of prevention and education, and putting into place a more responsive and sustained support system across the different communities. The other one, and I think Brent already mentioned this, and I really want to stress this, we always talk about collaboration, but we need to unpack that and really understand what that means, and how do we bring together public systems like health systems with their own structures, infrastructure, jurisdictions, mandates, and so on, with community groups that are playing to different tunes and different structures and mechanisms and rhythms. And so we need to learn some of the things that we've done very well in this initiative, but also where some of the gaps exist. Like, for instance, if we can shorten the distance between understanding the situation of individuals and collectives into response, right? Shorten the distance between referral and response, especially in this pandemic. And we've done a lot of that in this situation, but it's really always good to put that into place. How do we make systems more responsive to the possibilities of outbreaks and the pandemic, and how do they connect with community groups in a respectful, collaborative, and effective way?
Great, thanks, Cesar. Brent, anything to add from your point of view looking forward?
Just that we're going to have to keep an eye and keep engaged with the meat processing plants. One of the questions was about the summer and increased heat that is occurring, and on our most recent visit, that was raised as an issue by the people working there, is that these are hot places to work in the summer, and the use of PPE and visors is going to make it even hotter for the workers. So that's going to be important for us to be working with the unions and the employer to keep on top of that.
Maybe that's a good segue, Brent. There were a number of questions as well in terms of roles of employers and unions. That's obviously one, to stay on top of the working conditions. Are there other things that you think have been learned from this experience in terms of what can employers do, what can unions do, what are the possibilities, so that we can really learn from what happened here?
Well, I think what we saw is some different actions by different meat processors. So another meat processor in Alberta identified JBS and identified vulnerable people within their work population early on, and excluded those people from work with pay and that. So again, to identify who's vulnerable in your population and try and make sure they're protected. Cesar talked about some of the impact of the incentives, and so again, need to be really careful in terms of management practices of what you're doing, and rather it's going to have an unintended effect, and just having a better understanding of people's needs. We didn't touch really on the carpooling, but I think for myself, in terms of thinking about carpooling, it's something you choose to do. It's a choice to do. For the people working in the plant, it wasn't a choice. It was a necessity. It was how they got to work, and be able to fulfill their commitments and to their family members, as well as to their employer. And so, again, working with the employer to put in place the alternatives to carpooling. I think, again, when I made my comment in terms of this too can happen to you, is really that where we are in Canada, this is really an opportunity with for us to be looking at what's happening in terms of the workplaces as we're relaunching, and making sure that we are identifying these situations where there's real potential in terms of for spread to be occurring, and making sure that the resources measures are in place to prevent that.
Thanks so much, Brent. Now, I warned our speakers in advance when we did the practice that we would end today's webinar with a lightning round, sort of a last thought to leave everyone with, something that you think people could take away with them. So, Cesar, I'm wondering if we can start with you.
Well, this pandemic, and especially my experience in Cargill, really helped me be illuminated on what I call pre-existing conditions that make people vulnerable to infection. Workplace conditions, public policies like temporary foreign worker, single employer situations. I think as we move towards a new normal, quote unquote, whatever that means, it is a time for us to really make a decision on how we will respond to these things that we have uncovered. Some of those pre-existing vulnerabilities and inequities in our midst. Will this be a recurring dream, or is this a wake-up call? I hope it's the last one.
Thank you very much. Deirdre.
You know, a big lesson learned is just that coordination and collaboration is needed, and, you know, a collective approach in terms of, and I don't think that this is going away, and I think that, you know, this was an example of, you know, how we can work together as a sector and provide support to employers and particularly to newcomers, and, you know, and appreciate the vulnerability and the vulnerable context that people are within, and really listen to their concerns and their fears and to address them.
Thanks so much. Annalee?
Yeah, well, in family medicine, one of my old mentors used to always say, why this patient presenting with this illness at this time in this way? And what he was getting at was context. It's all about context. And certainly context is incredibly important in a pandemic. And so you need to look at those contextual factors and address that in order to curb the pandemic. It's not enough to say, don't carpool. You need to understand why they carpool, and you need to put the supports in place to help them get to work in a safe manner. So that's my takeaway, context.
Thanks, Annalee. And Brent, rounding us off. Oh, Brent, you're on mute.
Emphasize the use of your community assets, and that there are the resources out there, and it's making those new friends or strengthening the existing friendships is going to be very important for us as we go forward.
Thanks so much. And on that note, I want to give a huge thanks to all of you for taking part in today's call, for sharing so generously from your experiences so that we can all learn from those, and hopefully, Cesar, to your point, make it a wake-up call for all of us very broadly going forward. My great-grandparents actually came to High River a number of years ago now as immigrants, and I know they would have appreciated the strength of the community that drew together in response, and your commitment to making sure that we're also looking ahead to what can come. So thank you so much also to everyone on the call today for joining us. As we mentioned along the way, we will be recording, we have been recording today's webinar, and we will be making it available. So please join me in giving a big virtual round of applause to our participants today. Thank you so much.